Hello, welcome to this post-Christmas CTSNet Beat podcast. In this week's episode, we have the end of an era as Albert Starr passes away, and we'll tell you a little bit more about him. We've got 3 great articles and 3 wonderful videos. The world's first robotic aortic valve replacement with CABG by Vinay Badwa. We've got an article on how bad are pure GGOs less than 30 millimeters by Eric Lim. We've got validation of whether Eurostar 1 or 2 works in endocarditis or not, and a great systematic review that I love on total endoscopic coronary artery bypass grafting. Systematic review, how good is it? These are some of the best videos we've ever done as well. Robotic-assisted tracheobronchioplasty, possibly one of the best operations you can do with the stitching robot. A spontaneously closed VSD presenting as a Gerbode defect. Find out what that defect is. And a single leaflet neocuspidization for aortic regurgitation in endocarditis. So much to get through. And also there has been some Christmas skullduggery. I will tell you about this in the full podcast. Albert Starr died this week, December the 11th, 2024. He was born in 1926, so he had an amazingly long-lived life, dying at 98 years old. And he really is one of the founding fathers of modern cardiac surgery. He was the son of immigrants from the Ukraine and England. And he came to the UK. His parents came to the UK. He was born in New York. He went to Columbia and then did his practice mostly in Portland, Oregon. But what he will be most remembered for is his incredible meeting with Lowell Edwards. This was 1958. Lowell Edwards was actually 60 at that stage, and Albert Starr was only 30 and a budding cardiac surgeon. They met together, and the concept was to create a durable artificial valve. Before this date, it's kind of strange to think that the longest lived person after any valve repair or replacement was 3 months. It just was not working. They were doing ASDs, VSDs, but they could not repair or replace a valve. And so there'd been loads and loads of different attempts, loads to try, but they came up with the Starr-Edwards valve, which was the first artificial valve. And obviously the rest is history. There are some wonderful obituaries, some really nice information. One story I just love was Philip Bryson, 1965. He learned that he had a life-threatening murmur. He'd been born with a defective aortic valve. He was 25 years old, and remember, at that stage nobody had been able to fix it. He'd just got married. He'd just moved to raise his wife and 4 children. He was 25. What was he going to do? Well, Albert Starr put one of the Starr-Edwards valves in him, and at 70 years old, he is still going strong. He became a hunter, a fisherman, a runner, and still works. So, it's countless the number of people that he saved. He became an amazing mentor. There've been loads of tributes to him from people that have been to see him and really had an amazing long-lived life. He actually carried on working as a practicing surgeon till he was 80 years old. So we all remember you, Albert Starr, amazing person, and a wonderful life lived. Well done. We've got some papers to go through, but the other thing I do want to address is the end of another era, maybe. So that was the end of Albert Starr's era, but is there a new end of an era for CTSNet? Just as a little recap, where did we actually begin? Well, CTSNet was actually created over 25 years ago. In fact, we're going to celebrate our 30th anniversary next year. But back in 1995, a very different era, Robert Repogel, who was president of the STS, started seeing this strange thing called the internet. And it seemed really interesting. It thought, wow, this could be great to get educational material to the the members of the STS. He talked to Bill Baumgartner, who was the next STS president, talked to Tom Ferguson, and they found a super cool young gun called Peter Green, who was a practicing cardiac surgeon. And he was really techie, and he thought, yes, I could make this happen. They actually went to Prague at EACTS, and they started talking to other societies, Paul Sargent in particular, and it was at that stage that they said, well, why just do it with the STS? Let's do it all together, all the major world societies. So the AATS, EACTS and STS all joined equally to create CTSNet. Interesting, the Asian societies also fully support CTSNet, but the three owning founders are indeed the STS, AATS and EACTS. And in fact, ever since that time, we've had a board of directors with equal numbers on each and rotating presidencies to take it all the way forward. And we are where we are today. I did a little summary of how well we're doing. Get 5 million page views a year. 420 videos were posted last year. And thank you for joining this podcast. It's really, really popular. We've had 26,000 views, and we do about 1,000 an issue, which is really nice. It's great to have you there. Now, just one thing you probably don't realize is how free it is. You don't need to log in. You don't need to give me money. You literally click on the website, away you go. And if you want to click someone else, it doesn't matter. So, I think that's a not to be underestimated factor, because we have full 4-time members of staff. We have a 20% paid for executive director. And actually that costs about $700,000 a year to bring you CTSNet completely free, not firewalled, don't even need a password, don't even need to log in, which I think is pretty cool these days when everybody else wants your lolly. Now, how on earth do we pay for this? Well, since 2009, I think this must have been a genius idea of Rob and Ray. They were two of the previous people that ran the CTSNet back in 20 years ago when it was in Baltimore. They did a deal with a career center. And they said, well, tell you what, so why don't you post some careers on CTSNet and we'll share the funds, if you do get one to be posted, and off we go. And actually that's grown massively. And probably you can tell me better than I can that actually if you want a job in the USA, you go to the CTSNet Career Center. We actually make $300,000 out of that every year, which is great because our vendor does it all for us, which is great. So that goes a long way to paying for our staff members and keeping it free for you. Where else does all the money come from? Well, we get some sponsorship, about $100,000. You probably get a few emails from us that look a little bit advertiserish. Yes, they are. We get $100,000 out of that. So thank you for opening them. And if you open them, it makes us look even better. Other adverts that you get through every now and again, or the website's about $50,000. And then our owning founding fathers, STS, EACTS and AATS, with a few other organizations, just give us a small amount, $65,000. That's how we pay for everything. And I'll fully admit, I get a little bit of cash. So thank you very much. I get $50,000 a year. And we also give $5,000 a year to all our senior editors for all the hard work they put in. And we try to base that on an hourly rate, just so that people keep doing it. And I think that has actually been really successful. So it is absolutely fabulous, and it's really great that we can bring you all this content for free. But there has been some Christmas skullduggery. But I'm going to take a light-hearted look at it, because we're going to play the Spot the Difference game. So here is our Career Center, the CTSNet Career Center front page. So take a little look at it, because we're going to play a game. The game is Spot the Difference. Right, now here is the new STS Career Center. Now, we were only made aware that they were going to do a Career Center a week ago, and then suddenly it popped up. Strangely, it looks quite similar, doesn't it? But spot the difference. Right, are the jobs different? Wrong. No, all the jobs are the same. is the cost of advertising the same or different? Right. Yep, it's cheaper to post an advert on the STS one. In fact, every single category is just a little bit cheaper, $50. So they've undercut us. How long have they both been in existence? Well, ours has been going since 2009 and pays for half our website, and the STS has been going 2 weeks. And how about resume reviews? No, that's the same. And how about the company? There must be a different company running this. No, just the same. So the only other thing different is the badge. CTSNet has been changed to STS. Now, this isn't so great, is it? Because we didn't know this was coming, and so we will probably lose all our income to the STS because they're really brilliant and they're very good at advertising things on their website. We actually have the same reach. They've got about 7,000 members. We've got about 8,000 American members registered, so it all goes to the same people. So it is quite strange, but don't worry, never fear. We've had a chat. So we had a big chat to the CEO of the STS and the president and a few other people. They do want to carry on doing the Careers Centre. And actually, they do point out, what does the STS do different to CTSNet now? So because, they do videos, they actually do a fantastic job. I love the STS website. I'm a member of the STS. It's really great. They actually now do really good podcasts. And I would like to give a big shout out to Thinking Thoracic Surgery by Erin Gillespie and a few other surgeons there. Some of the thoracic podcasts are brilliant. They did a really good one on the recent World Lung. Great one on a guy that set up CT scans in a Winnebago to create his own lung cancer screening. Really good one on esophageal perforation. So they're doing a wonderful job, really. But so it turns out, really, the only thing that the STS weren't doing that CTSNets do was a career centre. So they decided, let's nick that. So I think really what it brings up is the major issue of the fact that the STS are my parents. Basically, they were the people that set up the CTSNet, Robert Repogel, Bill Baumgartner, the founding fathers of CTSNet were in the STS. Also, you may not know that the 4 staff members sit in the STS building. But the STS don't love us. They do want to have everything we have. And so that's not great. And if they do transfer over completely, which they have done already, the Careers Centre, we will basically have half our income. And so we'll need half our staff. And that's not great. But the bigger issue is that they actually own us 1/3. So if your parents don't want you to exist, that's not a good thing. But the good Christmas cheer is we're going to come to a resolution. Now, the options are quite good, really, because I think seeing as we're in the STS office and STS like all the stuff we're doing, maybe we should just become part of the STS. Maybe STS should just take it all over. Maybe CTSNet can be STS International, which would be quite fun, really, wouldn't it? Now, the alternative is we become EACS International or AATS International, but really, we're looking for a home now. So I've packed my bags, I'm ready to go, and I'm looking to see who would like to be the new home of CTSNet that will love and nurture us. And actually, what I think we're really good at is professional content, maybe really high-quality videos, regular weekly podcasts, and I don't know, you tell me what you like. So maybe one thing you like is a little summary of the week's papers, because that's what we bring to you every week on the podcast. So we'll get diving right into it. So one of the papers we are highlighting is heart surgeon performed the world's first combined robotic AVR and CBG. This was posted on December the 3rd, 2024. And basically, Vinay Badwar, fabulous surgeon, has done what is described here as a groundbreaking procedure. I would totally agree. A 73-year-old Poppy McGee, history of stroke and brain surgery, quite delicate person, needed an AVR graft, but that would normally have to be, and all of us would usually do a stenotomy for that, usually as a contraindication to minimally invasive surgery, but no longer, because as we'll see on some of the systematic reviews we're going to review a bit later, coronary artery bypass surgery can now be very successfully done minimally invasive invasively. So Vinay Badwa has put this together. He's actually a total world expert on robotic AVR, and he has now combined that with his knowledge of minimally invasive CABG to do the first ever AVR on graft. So well done him. We are actually in contact with his secretary, and hopefully we'll get him on the podcast to talk about how it came to be, because one thing I always find when I talk to these groundbreaking surgeons is it takes a lot more effort than just to have a bash. You literally can't do that, especially in our highly regulated world. We've got to think of the patient first, and I think he'd spent a huge amount of effort going through the safety steps to make sure that at West Virginia University Heart and Vascular Institute they were happy to do this novel approach. I'm sure he would have set a load of parameters for when to convert to open, but he did a wonderful job. So well done, Vinay. We will, as I say, try to have an interview with him in January, and we'll bring you more news about this wonderful breakthrough. The second paper is a thoracic paper, and it's a great systematic review from the ninja of systematic reviews. That's Eric Lim and Ashkay Patel and a few others have worked together to create this systematic review. The title of it, Prevalence of Invasive Lung Cancer in Pure Ground Glass Nodules Less than 30 millimeters, a systematic review. And this is in the European Journal of Cancer, December 2024. Now, Eric, as many of you will know, is a fantastic professor of surgery at the Brompton. He's very involved in the IASLC. Obviously, Peter Goldstraw was a previous professor there who pretty much ran and created the whole IASLC for the proposals for how we stage our lung cancers. And actually, there have been some proposals that we're going to class all pure GGOs less than 30 millimeters as just tumour in situ because of the benign nature of these GGOs. It's been quite an ongoing war over the last few years, especially as in Asia they have a very prevalent practice of taking them out, whereas in the West we leave them in quite a lot, or follow them up, or wait till they become solid. And the recent European guidelines will basically say leave them in until there's a solid component. So Eric and his colleagues analysed 3,874 individuals with a pure GGO less than 30 millimeters in 28 trials. Looked through systematic review. Quite a lot of these trials were in Asia, 25. Quite a lot retrospective, but I don't think that matters too much. And basically looked at how many actually uncovered a real, actual invasive cancer. So they report in the title that the incidence ranges from 0.9% all the way to 100%, obviously very small numbers, and the pooled prevalence was 42% of invasive cancers in pure GGOs. Now, if you do look further deeper down into the paper, it does sort of highlight there is really a big variation. Not just big, just insanely big variation in the prevalence of what they call invasive cancer in their GGOs. And exactly as they say, from less than 1% to all of them in these papers. Now, the smallest papers are 13 patients, so they're pretty tiny. Biggest patients, 1,000, of which only 9 had invasive cancer. So, what do we make of all this? My big question, Eric Lim says, don't be so glib about pure GGOs. You're going to send it to a pathologist, and the pathologist will say that's invasive cancer. My question mark is, let's not necessarily trust what the pathologists are looking at down the microscope, because at the end of the day, what is the definition of an invasive cancer? Well, to me, it's ability to metastasize. And in this paper, there is no note of how many then went on or had discovered at the operation the positive nodal metastases. And actually, that is the paper that I want to see. When we were doing this with the European guidelines, we were basically seeing virtually no papers that showed pure GGOs less than 30 millimeters spread to the lymph nodes, because that to me is the definition of when they've metastasized. And also the 5-year survival after surgical removal is near 100%. So, if it's not going anywhere when you've chopped it out, obviously Eric would say, few, I'm glad we chopped them out, but I'd say, well, if none have accidentally metastasized, maybe we're operating on them a bit early. But I think this is a really thoughtful paper, very well done by Eric and the Brompton team, and it does call into question our conservativeness in the West, and highlights perhaps that maybe the Asian surgeons are onto the right thing. So watch this space as to whether it gets downgraded or not in the next edition of the ISLC staging manual. The next paper, a cardiac paper, is looking to see whether the Euroscore is fit for purpose in infective endocarditis. This is by Floris Heijnen and Wilco Tannis. It's from the Netherlands, and it's in the European Journal of Cardiothoracic Surgery. Basically, they took the Netherlands Heart Registry between 2013 and 2021. There's 2,569 patients with infective endocarditis, and they did Euroscore 1, Euroscore 2, and they looked at the real mortality. So the real mortality in the Netherlands for infective endocarditis is a very respectable 10%. I think that reflects very well on the surgeons there. Euroscore 1 just completely over-predicted mortality across the full range of patients, but Euroscore 2 was only over-predicting when the mortality was coming out at about 20% or more. So the conclusion of this paper basically says that don't use Euroscore 1, but then nobody is, and Euroscore 2, you can use it, but if it starts saying above 20%, take a big pinch of salt out and chuck it all over the patient, and actually if that patient looks like they might be a goer, then just use your clinical experience and maybe don't deny patients emergency endocarditis surgery just because Euroscore shows 30% or something like that. So yeah, a good balanced paper, very interesting, and we all see endocarditis patients, especially the higher risk ones. So just have caution if you use Euroscore 2. This next paper, I've just alluded to it a little bit earlier because I loved it. It is entitled Totally Endoscopic Coronary Artery Bypass Grafts, a systematic review and meta-analysis of patient-level data. So this is by Ioannis Zupas and Konstantinos Myalonis, and they the senior authors from the University of Rochester, and the first author is from Athens in Greece, a junior doctor. And this is in one of my favourite journals, Innovations. I just love reading that every month because they pick out the really interesting, innovative stuff. And what did they do? Well, they got 2,774 patients, but remember this is patient level, so they went and got out the patient level data, so well done. 18 studies, and average age 63, so a little bit younger maybe than some patients we see for open surgery. And basically, this paper just documents what it's like to do a minimally invasive CABG, because I think a lot of surgeons are really, I don't know if the word's scared of it or just don't want to take it on because it's such an effort. So how much effort is it? Well, mean operative time, 304 minutes. That's 5 hours. So that's quite a long time, isn't it? That probably is a single case day, isn't it? But that's a long time, plus or minus 155 minutes. So that means it's, the other interquartile range can be about 7 hours. Mammary artery takedown time averaged 38 minutes. So I think people have got that down to a pretty nice, good, fairly decent cadence, which is really good to see. 4.7% conversion rate to open surgery. I think that is tremendously impressive. That's really good. So for every 100 patients, you'll only convert 5. I think that is excellent. And 30-day complication rate, only 6%. Late complications, 4%. Looks like less wound infections, better mobility. Freedom from adverse cardiac events, 93%. 1 year, 5 year, 10 year survival, 95, 83, and 81% 10-year survival. So, probably because they are younger patients. Reintervention only required in 3.3%, which I think is absolutely fantastic. So that does include PCI. So if actually you've only got a 4% conversion rate, you've only got a 3% with follow-up of about 5 years needing fixing your grafts, then you're getting your grafts right. you're getting your operation right and you're getting good outcomes for your patient. You're getting low complication rates. So I think this is a resounding fantastic for endoscopic CABG. Obviously, it's not for everybody. It is a very long procedure when we can do, a triple heart bypass, in a 2.5 hours or something. So you are doubling the length of the operation, but actually maybe they recover a lot quicker. It didn't go into recovery times, but really, really good. And I hope in the next 5 years we do see a whole slew of hopefully robotic or minimally invasive CABG videos, studies and trials coming out. John Januszewski's not here. He's on his holiday. So as you might have guessed by the fact I'm on a single camera, I'm doing all the editing this week. I'm on my lonesome between Christmas and New Year. So you won't be hearing anything from the CTSNet office, but it's all in rude health on our website. We're pretty soon going to update our website. It's going to be a lot whizzier. We're going to start creating atlases of all the operations. So actually, we're going to have a big picture of a heart, we think. And if you're interested in, say, a mitral endocarditis operation, you can go along that picture, click and find all the mitral endocarditis. If you like robotic segmentectomies, go along the heart picture and find a segmentectomy, and hopefully all of them. And congenital, which we might start with, we will go around all the cyanotic, acyanotic, atrial septal defects, ventricular septal, shunt procedures in a beautiful pixelated atlas, so you can actually steer around all these videos according to what you want to see, not just what we've posted in the month. So that should be very exciting coming next year. Let's look at our videos for this week, because I think there's some absolute bangers. So there's first one's thoracic, and then there's a cardiac, and then sort of congenital. So a little bit for everything here. So the first one is a robotic assisted tracheobronchoplasty for tracheomalacia. Now, if there's one operation that was designed for the robot, it is this. Remember, the robot is basically a big stitching machine. It was set up, in fact, to do cardiac surgery. That was the first operation. That's why the instruments are like Castros, your hand controllers, and actually. And they set it up to do stitching because stitching was too difficult minimally invasively. So tracheobronchoplasty is basically stitching a big, long polypropylene mesh to the back of the trachea and the left and right main bronchus. So what a fantastic thing that we've got a fabulous video from Chris Wisnick and Wilson Tsai. They're from New Jersey and Sutter Health Medical Center, Concord, California. So, and Hoboken University Medical Center is Chris Wisnick. So, and they've done a really great job of this video. The patient's got tracheobronchomalacia, but I've done quite a few open ones, and it's such a pain in the ass. It's a huge, big incision for somebody that's short of breath anyway. They're usually not in great nick, these people. So what a brilliant idea to bring it to the robot. It's so easy to mobilize the trachea. You'll cut the azygos. You can see the left and right main bronchus very beautifully from the right-hand side. I think the CO2 really pulls the right lung forwards even better, even than open surgery, and you just get the fabulous view. And this video just shows it so nicely. They get a polypropylene mesh. They'd show you how to use 4O to suture it along the costal cartilages and then to tether it to the membranous bronchus to stop it billowing forwards. And they do 3 polypropylene meshes, so one on the trachea, one on the right main bronchus, one on the left main bronchus. Look brilliant. Literally, I want to do this tomorrow because it was so clear and a great job. So if a thoracic surgeon likes a bit of robotics, do go and have a look at that. And then maybe toddle along to your respiratory physicians and see if there are any people with tracheomalacia that maybe they thought was too high at risk for an operation, because I think the recovery from this is just going to be an order of magnitude better than the open version. The second video, that's absolutely fantastic. All I can say is, if this was actually in the innovations competition, maybe it would have won. It's just so great. So let's get into it. This is which I love, from India, from the Mission Hospital at Durgapur. It's by Chaitanya Chittimuri, senior author Rahul Bose, and it's just a beaut. So it's called Spontaneously Closed VSD Presenting as an Iatrogenic Gerbode Defect, but it's so much more more than that. The animations are insanely good because this is a difficult problem to get your head round, but they have animated it insanely well. It's wonderful. And they go through a really interesting story. So the interesting story is a 29-year-old female, rheumatic heart disease, severe mitral regurgitation, and a bit of tricuspid regurgitation. So taken to theatre, caudal preservation, mitral valve replacement with a 31 mechanical prosthetic valve. Great, job done, fantastic, extubated, but then things weren't so great post-operatively. There's a bit of a pleural effusion, bit of a gradient, bit of regurgitation on the tricuspid valve, and then the drain started draining lots of pleural fluid. She got a bit septic, the antibiotics started going up, and so then on day 5 they did an echo, and basically the long and the short of it is they suddenly found free tricuspid regurgitation and a massive jet LV to right atrium, and that's what a Garbodi defect is. It's a shunt, a hole basically between the left ventricle and the right atrium. Now you're trying to get your head around this, aren't you? Go, well, how have they got a hole between the left atrium and right ventricle? Right, so left ventricle and right atrium. Well, they do a beautiful picture. And they go back in, and the answer is one of the stitches was a bit too deep on the mitral valve. What did it do? So it stitched through the left ventricle. It stitched into one of the leaflets of the tricuspid. It pulled a hole into probably what was a just about closed membranous VSD that was there anyway, and tore a hole through the left ventricle. It's caused a jet going into the right atrium through a hole in the tricuspid leaflet. Holy moly! But there's a beautiful picture of it on the illustration. So they go in, show us the second redo stenotomy. They put a lovely patch on the membranous VSD. They fix the tricuspid valve, and it's a happy Christmas story because the patient does really well. They get out of hospital, job's a good and lovely job, and the patient goes home 4 days after they discover this. So I've learnt a new word, Garbodi defect. I know what it is now. I've seen all the pictures, and I just think that is a wonderful video. Well done, guys, from India. And the third video we've got for you is called Single Leaflet Neocuspidization for Aortic Regurgitation due to Infective Endocarditis in an Adult Congenital Patient. Again, from India. Karthik Patel and Vartika Jain. They're at the UN Mehta Institute of Cardiology and Research Centre. And again, I just want to say there's amazing stuff coming out of India. It really is, a hotbed of cardiac surgery innovation, and we just love getting these videos. This was actually part of the innovation video competition, and it did go really, really well. If you want to see the other innovation competition winners when you've got a bit of spare time with a Christmas turkey inside you, then do click on the website, have a look at the best 3, because this didn't make the best 3. I can't believe it, because it is really good, really interesting. So what's the story? So the story is an 18-year-old female had chest palpitations and basically endocarditis, come to the operating room. And not only did they had a right coronary cusp prolapsing with vegetations on it, but they also had a small perimembranous VSD with some vegetations as well. So yeah, you've got a pretty bad problem here. Severe aortic regurgitation, very young person, VSD, nightmare. Because what you're going to do, you don't want to put a mechanical valve in because there's vegetations around. You don't want to put a biological valve in. So repair, but you've got a missing right coronary cusp and you've got a VSD to fix. So they do a wonderful job. They basically, through the right atrium, they fix the perimembranous VSD with an autologous patch, and then they take the patch. Second bit of the patch, they put glutaraldehyde on it to treat it, and they use this autologous pericardium to construct a new right coronary cusp. They go through how they measured it, and then they go through in really beautiful detail how they affixed this to the annulus, attached it to the other cusps, and got beautiful coaptation. And TOE shows wonderful coaptation, no regurgitation, virtually no prosthetic material in this patient with endocarditis. Absolutely wonderful job. So replace. It's a kind of Ozaki procedure sort of thing, and yeah, really nice job. Well done. So that's our articles, that's our videos, that's what we do at CTSNet. We bring you what we think is the best articles and the best videos every single week. We've brought you 420 videos this year, all from people that send that to us purely for free. We also hope that in 2025 we're going to have a very exciting new year. Certainly going to be exciting, isn't it, for me? Because we're going to try and work our hardest to keep it all free for you. We'll try and see who wants to support us out of our major institutions. But I'm pretty confident that they'll fall back in love with us. I'm pretty sure they will. And we'll happily carry on doing what we're doing today. Interesting things coming up. So the most interesting thing is the residence video competition. We've just had an innovation competition and we've interviewed the winner, so we'll bring that to you very shortly. They won $1,000. So if you're sitting on a video about to send it to us and you're a resident, don't just send it to us, send it to the video competition. You could win $1,000, which is great. And also say you're a CTSNet International competition winner, which is big kudos. So the deadline's the 10th of January. So get working between the Christmas and New Year period for your favourite video, and we'll announce the winners in January for that. So that's about everything for this week. Apart from the VIP clubs. So thank you very much for staying to the end of the podcast. At the end of our podcast every single week, we talk only to our very important people. And the definition of a very important person is A, if you stay to the end of the podcast, and B, if you'll join our WhatsApp group. So send me a WhatsApp on +44 780 154 8122, and you can join our extremely elite group of VIPs. Just like Mahmoud al-Baghdadi. Now, he has been a VIP member for a little while, but one of the things I did say for my VIPs is if you need any help with any videos coming through CTSNet, I will sort it out. So he reached out and he said, wait a sec, you guys take a little while with my video. And so I sent some emails around, we dug it out, we reviewed it within a week, and it's all done and dusted. So accepted for publication, and Erica will give it a date very, very shortly. So a little bit of a service for our very special people, because it's you. You are our special people. And welcome to Rodrigo Rostro. He indeed WhatsApped me last week. He's a thoracic surgeon who loves trauma and also uniportal and pleural disease. He's 42 and he works in private practice in Guadalajara, Mexico, and the home of tequila, he tells me. So welcome to our VIP club. Thank you for listening every single week. And next week, we're going to do a slightly special edition. We're going to do a wrap-up of the whole year. We're going to kind of maybe tell you our favourite things of the whole year. So I hope that'll be really interesting. I hope that'll be popular for you. So carve out a little time, because you'll probably be thinking of your New Year's resolutions. Why not go on a run or sit on an exercise bike and listen to me next week, where I'll bring you the roundup of the whole year on the CTSNet Beat podcast.